And picking up where we left off last week, we are now on module 9, only one more week to go after this. And it's really just going to be kind of a partial week next week. So today, let me explain where we are, where we have been, and where we're going. We're going to be working on kind of the pathophys of the urinary today. Thursday last week, I had gone over a lot of the basic stuff, and it never seems very basic when you're doing urinary because everything's so freaking complicated. But the basic stuff, meaning like what's the basic anatomy of the urinary system? What is its general functions? What are the parts of the nephron? You know, how does the nephron relate to a capillary? You know, specifically when you're talking about a glomerulus, you know, what's a macula densa? What does GFR mean? And then the renin-angiotensin-aldosterone pathway. So if you understand those ideas about urinary system, you're golden. Like that's the bread and butter right there. And then when you look at, well, what if I'm running the renin-angiotensin-aldosterone system in a state of congestive heart failure? You'll be able to figure things out. So I'll explain that today. Because one thing that we want to do with the urinary system is make sure that we get all the basics, because it's one of those systems that when it fails, you get multi-system dysfunction. And so it's hard to tell exactly where it's coming from, but some clues will give it away. So again, I'll explain a little bit more about that later. And when we get into types of renal failure, I'll explain where they can come from in the anatomy. Just basics of the anatomy helps right there. When we get into hormone disorders, you know, how is that going to affect the renin-angiotensin-aldosterone pathway? If we know that there's a kidney problem, but I'm seeing certain things pop up in the urine and certain things are not, we can actually tell where it's coming from by knowing the basics. So again, the basics are kind of the key. But again, that's what we did last week. Today, we're going to talk about where the system is not functioning appropriately. So when the hormones are not working appropriately, if the kidneys themselves are infected or any type of gobbledygook going on. We'll talk about renal failure. We're going to talk about Addison's disease, diabetes insipidus. We'll talk about nephritis, pyelonephritis, infections, all that kind of good stuff. This Thursday, we're going to be talking about the digestive system. Again, we're going to kind of do the basics on Thursday. Next week, we'll talk about where the system falls apart. So this is not a terribly difficult system to visualize what's happening. When you first learn the digestive system, the trick is you're trying to form a mental image of what's happening every step along the way of the alimentary canal. So that's what we're going to do Thursday. We're going to start in the mouth. We're going to chew the food up. We're going to add saliva, talk about what enzyme is added in the mouth, and then we're going to go from there. So we're going to go down the esophagus, through the lower esophageal sphincter, also known as the cardiac sphincter, into the stomach. And then what are we going to do there? And then we're going to go through the pyloric sphincter and talk about the duodenum and the jejunum and the ileum. What do we do there? Where do we add stuff? What stuff are we adding? Where is it coming from? And because everything's traveling through tubes, you know, you have the alimentary canal itself, and then you have these tubes that are coming from accessory organs, like the common bile duct, the pancreatic duct, the ampulla of Vater, all that kind of stuff. You know, one of the simple ideas about the digestive system is, well, what if one of those tubes get blocked? You know, that's going to lead to a lot of issues. So if you have some type of GI obstruction, if you have a gallstone, if you have pus, you know, what's going to happen, or what would we see when the system's not running appropriately? So again, it's not a mental stretch by any stretch of the imagination, but there's plenty of stuff, obviously, that we can go over when that system's not working appropriately. So again, similar to urinary, we kind of did the basics last week. We're going to talk about the pathophys today. Digestive on Thursday this week, we're going to talk about the basics. Next week, we'll talk about the pathophys. And then cancers, we're going to kind of keep it pretty short. This is going to be essentially, I'll just go ahead and open it for you right now. A top 10, I believe it was, of the most common types of cancers that we see in the United States, at least. Not necessarily the world. But let me see. We're going to go over like the basic idea, like what leads to cancer, like how would we grade it maybe. I mean, we don't have to do that, but we can talk about where that grading system comes from. Like if you're in stage 1, stage 2, stage 3, stage 4, it's not really a hard thing to do. But we're essentially just noting the mechanism of cancer. Like cancer is essentially due to the fact that your body has to maintain itself over a lifetime. And in order for your body to maintain itself, cells have to divide, right? We have to replace old cells with new cells sometimes. And if we're doing that in a healthy way, then the cells should look just like their previous generation cells that they came from, right? But if we start to see that that's changed, that's usually not a good idea. And sometimes the body's doing that to help you a little bit, because maybe there's something you're doing to the body that's not so good for the body. So the body's trying to fight back. But any type of cell change over time, we usually call metaplasia. And metaplasia is usually like the step that we end up seeing before cancer happens. So we'll talk about, again, staging of cancer, like metaplasia, anaplasia, dysplasia, all that kind of good stuff, which eventually leads to metastasis. And once we talk about that basic idea, we're just kind of running through them. So it's not going to take a lot of time for us to say, hey, here's number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, because it's just a quick reference guide that you can use when you end up taking your final exam. And the idea is, if you're getting questions on your final that talk about cancers or neoplasms, this is probably the place to look for it. But melanoma is a good one to do. We'll probably talk about that one because it's easy to visualize exactly what's happening. And we'll kind of pick and choose some of the ones that we go through. But the reason we're going to intentionally keep this short on purpose next week is, if you look at our schedule, we pretty much run out of time at that point. So the other thing that we need to do with that day, which will be the 3rd, of next week, is we need to do a Q&A. So if you have any questions about, urinary, if you got any questions about digestive, if you have any questions about previous material, labs, neuro, cardio, then we need to have a day to go over that stuff too. So that's primarily what we'll do this class. Again, I'll go over the basics of cancers, neoplasms, but we'll probably do a big Q&A that day for any questions that you have left. And then our final exam is due soon thereafter. So it is kind of running right up against the wall here, because the final class meeting is 8/3. The final exam's due by 8/4, but it is open book, open note. There's a time limit to it. So I want to show it to you, but if I enter into it another way, I can show it to you, but let me just explain to you. It's a 2-hour exam. There's going to be 50 points, but it's not necessarily 50 questions. Some of the questions are going to be matching. So I think there's 3 questions that have matching. So you only end up with maybe 41 or 42 questions that you have 2 hours to do. But the trick is it is comprehensive. So I can be pulling information from neuro all the way back here. I can be pulling information from fluids and electrolytes. I could be pulling information from the blood, like blood immunity and labs. And you might get a combination, a mixture of some of those things. So I might say, here's the sign and symptoms we're going to see. Here's how the lab shows up. So for example, if I'm dealing with some type of autoimmune disease like MS is, your signs and symptoms are going to be very neurological, because MS typically attacks the upper spinal cord and the cerebellum first. What's the cerebellum do? Well, we start to lose coordination. So maybe I'll see nystagmus in the eyes might shake. Maybe their speech is a little bit stuttered or staggered. We sometimes call it scanning speech. They might have intention tremors because they end up having dysmetria and a general lack of coordination. And then on the labs, we might see elevated erythrocyte sedimentation rate, or C-reactive protein, CRP. So again, you'll be kind of getting information that we covered under multiple chapters, but they all kind of go together. And that's literally what kind of diagnosis and pathophysiology is all about. It's putting all the pieces together into some type of usable form where we're taking the basics showing to you in a broken form and then wondering what happened, and how do we treat it? So with MS, you're essentially dealing with an autoimmune disease. It's inflammatory in nature, so we want to stop the inflammation. So maybe some type of steroid treatment, maybe some type of immune suppressant drug would help with that, slow it down a little bit. So that's the idea. But again, it's going to be open notes, open book, open Google for all I care. I really don't care how you come to the answer, but it would be easiest for you if you are as familiar with the PowerPoints as you can be. So literally, if you just want to take a day sometime this week just to scan the PowerPoints, be like, okay, this is talking about MS here. This is talking about myasthenia gravis. Here's the slide for Guillain-Barré. Literally go make you a sheet of paper that tells you which PowerPoint it's in, what page it's on, because there is going to be a lot of questions about Pathophys. That's one of the goals of the class, is not only to review the regular physiology, but essentially what happens when that physiology is not working anymore. So that's the idea. And again, I'll talk about it more next week too, because we'll be right on the cusp. So I'll mention everything again next week and maybe come up with some type of motivational speech or something. Who knows? But today, before you all fall asleep, we're going to do urinary. And I literally already opened my PowerPoint. So let me get rid of this one real quick. Jump into this one right where we left off last week. So one of the last things we ended up doing last week was we talked about the renin-angiotensin-aldosterone pathway. Super important pathway. Information that comes from this you'll be able to use to help treat things like hypertension, right? Because with the renin-angiotensin-aldosterone pathway, the gist is, like, just real brief, if I have a decrease in blood volume and that creates a decrease in blood pressure, and that eventually decreases my CHP or capillary hydrostatic pressure at the kidneys, that's also going to decrease the GFR. So that's no bueno, right? We can't have a decreased GFR in the kidneys, because anytime you have a decrease in GFR or you have buildup of waste in the blood, then that's essentially termed urinary failure. And nobody likes to be called a failure, right? So the kidneys, that's a problem for them. So renal failure, failure of the urinary system, it can all start with this. So we have a system specifically designed to maintain GFR, even in a low volume state. Even if we start to become hypotensive, we have a system that can fix that, because we don't like to fail as a urinary system or the renal system. So when the GFR goes down, you have these things called juxtaglomerular cells, and juxtaglomerular cells can release a hormone called renin, right? And this is, again, part of the renin-angiotensin-aldosterone system, or pathway, they sometimes call it. And that starts a chain of events. It's a positive feedback loop where we'll take angiotensinogen, which is an inactive precursor. So OGEN is the beginning of, that's literally what it means, genesis, the formation of, or the beginning of, O, so the beginning of angiotensin. So it's not there yet, but renin will help get it there a little bit. So that'll turn angiotensinogen into angiotensin 1, which is a really, really, really weak vasoconstrictor. I'm sure they'll find something amazing that this does later that we don't know about, but as of right now, I'm just telling you it's a really weak vasoconstrictor. So in order to make this useful to us, specifically as part of the system, it needs to come in contact with an enzyme in the lungs called ACE. And so the lungs is just where we have a high concentration of ACE, right? Body does that sometimes. We sometimes separate where things start, where they end up. So it gives you a chance to say, are you sure you want to do this, right? So as long as we got enough angiotensin 1 floating around in the blood, which the longer this system runs, the more you'll get, because the more angiotensinogen is going to come in contact with it, then more of this will come in contact with ACE, and then more angiotensin 2 gets produced. And in the presence of angiotensin 2, not only do we get a very strong vasoconstrictor, right, which is going to help reestablish the blood pressure. One of the specific things we're going to do is vasoconstrict the efferent arteriole. So we're going to get general vasoconstriction, but we're also going to get very powerful vasoconstriction of the efferent arteriole of the glomerulus, which will help back up the system. So even if you got less fluid coming in, it'll back up, it'll congest, and then it'll start filtering again because it can't get out. All right. But you're also going to get increased aldosterone production, which we're going to talk about in just a jiffy, and you're going to get increased ADH production, which we'll also talk about in a jiffy. So that leads into our first conditions today. One of the conditions is going to be called Addison's disease. So let me go into the notes. And we've seen this before. So on the very next page, slide 20, you start to see problems with aldosterone production. So let's talk about, where does aldosterone come from? What's the normal stimulus for aldosterone production, which we just covered, which is the renin-angiotensin-aldosterone pathway. We'll talk about other reasons we can produce aldosterone, and then what would happen if we don't produce enough aldosterone. Okay, so that's called Addison's disease, and it's easier for me just to do it on paper. Right? So the most powerful way that we normally release aldosterone, and the strongest stimulatory effect for the release of aldosterone, is through the renin-angiotensin-aldosterone pathway. So the presence of angiotensin 2 will do it. So once angiotensin 2 is floating around in the blood, then aldosterone is going to be better released from the adrenal cortex. Okay. So again, the adrenal gland, which sits on top of the renal part of the body, which is the kidney. So this is a renal kidney. This is adrenal above the kidney, sometimes called suprarenal, because supra means it's sitting on top of. The outer portion of the adrenal gland is where aldosterone is going to come from. So when we look at, again, the adrenal gland, the middle part is called the medulla, because that means middle. And that's where certain catecholamines are produced, like epinephrine and norepinephrine. So if I want to put the body in a body-wide state of fight or flight, then that's the part of the adrenal gland that gets stimulated. But other hormones like aldosterone, cortisol, and adrenal androgens come from the outer part of the adrenal gland called the cortex. So again, here's the cortex of the adrenal gland. Here is the medulla. Okay. So the cortex is where aldosterone is going to come from. And specifically, it comes from a place called zona glomerulosa, right? So again, this is just a refresher of endocrine. I'm not too terribly concerned that you memorize this again, but again, if it pops up on a board, there you go. So the mnemonic I was taught when I was in school, to remember what hormones are coming from the adrenal cortex, which part of the adrenal cortex is producing them. We used GFR, which, funny enough, we're talking about the urinary system now, right? That's where GFR came from, but we can also use it as a mnemonic for the 3 layers of the adrenal cortex. So again, GFR is not famous because of the 3 layers of the adrenal cortex. GFR is famous because it stands for glomerular filtration rate. But I can use that same abbreviation, which we know now, to also remind me, well, what are the 3 layers of the adrenal cortex? Well, you got zona glomerulosa, zona fasciculata, and zona reticularis. And they produce families of hormones. And the family that comes from zona glomerulosa helps us deal with salt control, like electrolyte balances, like sodium and potassium. And so they're called mineral corticoids. The one that's coming from zona fasciculata helps us deal with sugar metabolism, because, believe it or not, cortisol is one of those hormones that actually helps with sugar metabolism. It's not why we think about cortisol, but that's one of its main functions. And then zona reticularis makes adrenal androgens, which is part of sex determination as a fetus. And it's also going to help with testosterone production later. So the mnemonic we remembered when we were in school was GFR, salt, sugar, sex. You knew the outer layer had something to do with salt levels. You knew the middle layer had something to do with sugar levels in the body or sugar metabolism. And you knew the inner layer of the cortex had something to do with sex. So this is where aldosterone came from, cortisol, and adrenal androgens. So that's where aldosterone comes from. So aldosterone is going to come from here. And again, the main driving force for aldosterone production is the renin-angiotensin-aldosterone pathway. So the longer this pathway runs, the more aldosterone the adrenal cortex will kick out. Okay. So what are the basic effects of aldosterone? This is something you always need to know. Aldosterone does two things for us. It's going to increase sodium reabsorption rate, which we're going to say that in a different way now. We're just going to say that's going to help us to keep sodium, right? And it's going to increase the potassium secretion rates. And when it's saying that, what it means is if I go through my nephron, right, your tubular system we can pull out of and we can secrete directly into. And let's just say here's the exit of the tubular system, which is eventually going to go to your renal pelvis, which is eventually going to go down a ureter, which is eventually going to go to your bladder, which is eventually going to be emptied. So if I make it all the way down the collecting duct, I'm leaving. We're not getting it back at that point. But anytime between here and here, we can change what's in this tubular system, right? I can pull out of the tubular system, and we call that tubular reabsorption. And you'll essentially pull back into things called peritubular capillaries. So it'll go back into the blood. So you end up keeping it, right? Because it pulls it back into the body. It's out of the tubular system. But I can also use peritubular capillaries to secrete directly into, right, the tubular system. And you can do that anywhere along the way. We just do most of our tubular reabsorption in proximal convoluted tubule. A lot of our tubular secretion usually occurs up here, but you can reabsorb and secrete anywhere. But tubular reabsorption means I'm going to keep it. Tubular secretion means I'm going to add it to the tubular system, which means I'm eventually going to get rid of it because I will excrete it once it leaves the body. So aldosterone increases tubular reabsorption of sodium, which means we're going to keep sodium. It also is going to increase tubular secretion of potassium. So it means we're going to get rid of potassium, okay? But that's in the presence of aldosterone. So the more aldosterone we have, the more we keep sodium, the more we get rid of potassium, right? And the reason we're trying to keep sodium in the presence of aldosterone is not only to control sodium levels, but it's also to hold on to water, because water is going to go wherever sodium goes, right? So that gets reinforced later in the PowerPoint when it talks about something called ANP, or atrial natriuretic peptide. And what ANP will do is the exact opposite of aldosterone. Aldosterone will take sodium from the tubular system out, and that pulls water with it, right? But ANP, atrial natriuretic peptide, can actually take sodium out of that's outside of the tubular system and push it in. So we don't reabsorb it as much. We can add more through tubular secretion if we want to. We can add more sodium in, and then water will follow, right? So wherever sodium goes, water follows. Aldosterone is going to pull it out of the tubular system. Atrial natriuretic peptide pushes it into the tubular system. Forget this for a second. Let's just focus on this, okay? So what does aldosterone do? It keeps sodium, therefore it's going to keep water, and it gets rid of potassium. What's the main driving force for aldosterone production? The renin-angiotensin-aldosterone system, okay? But you could also produce aldosterone in, say, a hyperkalemic state. So that's another stimulus for aldosterone, right? Hyperkalemia, right? Maybe hyponatremia, right? But this one's more powerful, because if I'm already low on sodium, wouldn't I want to keep more, right? So that could stimulate aldosterone. If I already have a lot of potassium, don't I need to get rid of it at a higher rate, right? So that's probably the second strongest right there. Hyperkalemia is the second strongest stimulus for production of aldosterone. But again, the main production of aldosterone is coming from the renin-angiotensin-aldosterone pathway, okay? Secondarily, hyperkalemia can increase aldosterone production. And then tertiary, we could also increase aldosterone production with an increase of ACTH, but it's very weak, because ACTH is a pituitary hormone that stimulates the entire adrenal cortex. But aldosterone really doesn't care. He answers to a higher power, right? So usually if you increase ACTH, you're mostly just going to increase cortisol. But if I'm low in aldosterone, will my pituitary start kicking out more ACTH? Sure it will. So when a person has Addison's disease, we can now figure out what's going on because Addison's disease is sometimes referred to. So Addison's disease, the problem, so let me just put what Addison's disease is, not enough aldosterone. That's the main problem. Okay. They sometimes call it adrenal. So another name for Addison's disease is adrenal hypofunction, which they're basically saying part of your adrenal gland isn't working as well as it should be. But the main part is the part that's producing the aldosterone. Okay. So Addison's disease, you're not producing enough aldosterone. So if I don't have enough aldosterone, what can I not do? Well, what does aldosterone do? Aldosterone keeps sodium, right, which will hold on to water, and it gets rid of potassium. This is what it normally does. But if I don't have enough aldosterone, then I can't keep sodium. So I become hyponatremic. I become hypovolemic, because if I can't keep the sodium, that means I can't keep the water, and I can't get rid of potassium, so I become hyperkalemic. Okay, so hyponatremic, hyperkalemic, hypovolemic, and one of the major signs and symptoms of Addison's disease is coming from this, in which they get what's called orthostatic hypotension. And the reason they get hypotension, low blood pressure, that's just HY. So let's clear that up a little. So orthostatic hypotension means I get low blood pressure every time I stand up. So every time I go from like a laying position to an upright position, or a seated position to a standing position, I feel like I'm going to pass out. That's orthostatic hypotension, right? Which you can get that without having Addison's disease. You can get that if you just have low blood sugar or you're dehydrated. But this will happen all the time, right? It'll happen all the time with Addison's disease. So that's the main sign and symptom that's going to give you this diagnosis, right? But you might also notice that the patient has cravings. They're thirsty and they have salty cravings because they want more sodium, right? And sodium chloride, sodium Na plus Cl minus, when they combine together, it forms an ionic bond, but in the body, they split apart, right? Creating some of our electrolytes, and both are found in the ECF and both hold on to water. So because they're hypovolemic, they're thirsty, and because they're hyponatremic, they're going to have a craving for salt, NaCl, and both the Na and the Cl can help hold on to water better. So they'll have salty cravings, they'll be thirsty, but then they also end up getting what's called hyperpigmentation. So these are kind of like your key giveaway that we're dealing with Addison's disease. Not any one of these alone, you know, hyperkalemia alone can't be Addison's disease. Hyponatremia alone can't be Addison's disease. But if you put all these together, hyperpigmentation of the skin, orthostatic hypotension, electrolyte imbalances, fluid imbalance, absolutely, that's Addison's. No doubt about it. And the hyperpigmentation can occur not only in skin, like across the face, the creases of the hands. So like sometimes the hands themselves will get darker and the creases get darker. But usually across the face, could be just somewhere randomly on the torso. It's not everybody gets it in the same place, but the skin turns a little bit more orange. Right? And it's due to an increase of ACTH production. And when you have too much ACTH floating around in the blood, that can actually cause the melanocytes in your skin to become overactive. So it starts to make the body turn a different color. So let's see if we can see an example of Addison's disease, hyperpigmentation. There we go. So here you go. You can see it in some people's tongues, some people's lips. Here's the hands that have turned much darker. See all the little creases, you know, where the knuckles are. Those are much darker. These usually get much darker. The face, the skin in general. See how orange that is? Here was the original color. Here's how orange it's become. Don't ask me why it, you know, is not affecting that area. And those melanocytes are just like, oh no, you're not fooling me. Here we go. Look at that orangey skin. But most people look like this with Addison's, like this. They'll get this little freckly portion across the eyes right there. It looks like they've just been into the tanning bed. It'll be difficult to tell, but they'll usually get that pigmentation across the eyes and the bridge of the nose right there. And you'll see that the hands are darker. So not everybody's going to be bright orange like that, or it looks like, you know, rub on or spray on tan. But usually across the face, you'll be able to see it, and on the hands, you'll be able to see it. That's what's going to give it away. You see that little kind of freckly rash across the face, then that's going to be Addison's. That's how you'll see it most often. And from now on, you'll not be able to not see it anymore. Like you'll go to the gas station one day and the gas station attendant's going to have Addison's disease, and then you're going to be, you know, saying, I wonder if I should say something to them, or should I not? You know, I would imagine it probably is more reversible now that they have creams and stuff that can do that, but it would certainly minimize once the disease was treated. You know, just like a tan can come and go, this is essentially melanocytes overreactive to ACTH. So once the ACTH levels go back down, the melanocyte activity should also go down. And eventually the skin moves closer to the surface and we shed it off. So it'll take time, but it should disappear, kind of like hands disappear during the winter. Let's say. So that's Addison's disease. We spent a pretty decent amount of time on that one, but that's a good one to know. That's going to cover 2 chapters right there. That's something that comes up with endocrine disorders, and this is certainly something that would come up with kidney disorders as well. Easy peasy. But again, with Addison's disease, the key is, well, what does aldosterone do normally? Now, if I take that out of the picture, what would I likely see? That's how you answer those questions. The next one we're going to talk about, I think you can find on the very next page, diabetes insipidus. So diabetes insipidus. So diabetes insipidus, basically just means really bad diabetes, right? It's just it's a bad type of diabetes. And the term diabetes itself means to go through. So anytime you have any type of diabetes, whether it's diabetes insipidus, diabetes mellitus type 1, diabetes mellitus type 2, you pee a lot. So some of the basic signs and symptoms of any type of diabetes, whether it's insipidus mellitus, the normal kind that you hear about, you get polyuria and polydipsia. That's where the whole term diabetes comes from, because the people pee a lot. So polyuria, pee a lot, and then because of pee a lot, I'm thirsty, polydipsia. So with diabetes insipidus, the difference in these signs and symptoms is they're extreme. So you get extreme uresis, extreme thirst. Okay. So this could be something that's being caused by a tumor. This could be something that's caused by some type of kidney disease. This could just be something that's just happening and you don't know why, right? But again, I guess the problem is it can occur very rapidly. Like you could actually get some type of pressure on the brain that ends up causing diabetes insipidus, and you could die within a day or 12 hours just by peeing yourself to death. You'll become so dehydrated that you'll actually die within just hours, just because you'll pee yourself to death. So that's how extreme it can be. Most people, it creeps up on you. So you'll start to notice that you're going to the bathroom more and more and more. Usually it's because of some type of pituitary tumor. But again, that's not how it has to present. So on the PowerPoint, it did say there's 2 types. So we sometimes deal with something that's called central, or maybe something that's dealing with a kidney issue. So central usually means there's something going on with the hypothalamus or the pituitary. Okay. I know that's not central in the body, but it's kind of central for where the hormone that's involved with diabetes insipidus comes from, which is going to be ADH. Okay, ADH production. So where does ADH come from? It comes from the hypothalamus. It's released through the posterior pituitary. So that's why they sometimes call that central diabetes insipidus, because that's where ADH comes from. That's like the origin of the ADH, the hormone that's involved with diabetes insipidus. And then if it's nephrogenic implies that there's something wrong with the kidneys, but it's basically the kidneys are no longer responding to ADH. So that's what it would mean if it was nephrogenic. Yeah. Or I guess if they're using the word central, they could say peripheral, right? I'm not familiar with that term, but it certainly could be. So different books will just call it different things. But again, what is the main issue with diabetes insipidus? Like, what's the difference between diabetes insipidus and diabetes mellitus? A lot. They just happen to share certain signs and symptoms, you know, which is increased thirst, increased urination. So polyuria is the increased urination, polydipsia is the increased thirst. But the cause of diabetes insipidus is some type of problem producing ADH or recognizing ADH. It's an ADH problem, right? And the problem with diabetes mellitus is insulin related, right? So I'm either insulin dependent or I'm not recognizing insulin. But again, this is going to be the more extreme of the two types, okay? So with diabetes insipidus, what could prevent ADH from being produced? Well, it could be a pituitary tumor. And in this case, like if my hypothalamus is right here, and here's something called an infundibulum. It's basically just a little stalk right beneath your hypothalamus. So here's my thalamus, here's my hypothalamus. Here's my infundibulum, and then here's your pituitary. Your hypothalamus is what's producing the ADH, and it's going to push that ADH along axons into the posterior pituitary, where it's then going to release it into the bloodstream, okay? But if I end up having like some type of big tumor right in here, that's going to prevent that from being able to get there, right? So sometimes people with diabetes insipidus, they end up having some type of tumor that creates pressure, right? So in order to treat the diabetes insipidus, we have to treat the tumor, right? But again, it could be some type of tumor that is temporary. And an example of a temporary tumor could be swollen blood vessel, so swollen blood, something. So it could be a vessel, it could be a clot, right? It could just be blood has displaced this area. So if you have a lot of bleeding out here and it displaces this area, it's going to put pressure on that stalk, right? So if you have a central brain bleed, like if you had head trauma and some of your lower arteries get messed up, it can put pressure on your brainstem and your hypothalamus. You know, the way you can tell on a patient if you have some type of kind of middle displacement of the brain is you'll start to see problems with electrolyte balance. You'll start to see problems with temperature, body core temperature. You'll start to see problems with pH all happening at once. And then it might also end up affecting respiratory rate and cardiac output, right? So if you start noticing all these things are getting all jacked up, you know this area right here and the brainstem, which is going to be like right here, are affected, okay? But again, pressure can cause that. So regardless, though, of where the diabetes insipidus is coming from, it ends up being an ADH problem, and I'm not producing enough. So diabetes insipidus, I'll just put DI, is not enough ADH. And ADH stands for anti-diuretic hormone, which basically says don't pee. So anti-diuretic hormone is the don't pee hormone. So if you ever want an idea of a loss of anti-diuretic hormone, go drink you about, no, don't do this. If you've ever been around, you know, these foul people that drink alcohol all the time, disgusting, right? Once you drink about 3, 4, 5 beers, I hear that you break a seal when you go pee and then you got to pee all the time. Guess what? There's no seal, right? It's just alcohol starts to inhibit ADH production. And when we don't produce enough ADH, you start to pee all the time, right? And then the next day you wake up and you're all hungover, and half of those hangover symptoms are due to the dehydration you're now experiencing from the decreased ADH production. So again, it's kind of weird to think about, but in the presence of antidiuretic hormone, I can hold on to water, right? Because it's saying don't pee. But in the absence of antidiuretic hormone, the water just flows out, right? So if I don't have enough antidiuretic hormone, water flows out very quickly. And it's a very dilute urine is what it is. So your electrolytes might all start to increase, like you might start to become hyperkalemic, natremic, hypercalcemic, whatever, because you're just peeing out water. It's just water coming out. Right? So it's a very dilute urine. So what do we end up seeing with people that have diabetes insipidus? Again, polyuria, polydipsia is going to be the main signs and symptoms. So pretty easy to remember. But over time, with your electrolyte imbalances and stuff going on, because you're starting to concentrate those things, fatigue is going to kick in, muscles will become tight, they'll get stuck and rigid, all that kind of stuff. Weight loss because of all the loss of fluid, loss of appetite and confusion when the fluid electrolyte balance gets all messed up. Right. So a person might start to go into almost a state of where they seem to be having neurological symptoms, like the confusion and stuff like that. But obviously, if this person's hooked up to any type of machinery and they have a catheter in, you're literally just going to have to weigh them. You're going to have to notice the difference between how much fluid have they taken in, like we've given them 2 cups of, water, how much fluid has gone out, they've peed out 2 gallons. That definitely would indicate diabetes insipidus. Okay. So pretty easy, pretty straightforward, right? So diabetes insipidus, it's a problem with ADH production, and the problem is I'm not producing enough. And if I can't produce a hormone that tells me not to pee, guess what I'm going to do? I'm going to pee too much. So what am I going to see? Increased urine, polyuria, increased thirst, right? But if it starts to get bad, then they're going to lose weight. That's how you might notice diabetes insipidus in a hospital setting. You've given them 2 cups of water, but they've peed out 10. Okay? So weight loss or weight change is a way to diagnose that. Okay? And then the confusion will certainly kick in. So if they have a head injury and they start having the polyuria and the polydipsia, this might be something you would want to think about. Okay? And then again, central versus nephrogenic. Here, we're essentially not producing the ADH, or we can't get it out in adequate amounts because, again, of pressure or a tumor. Right? So it could be, again, pressure from blood vessels that are swollen or blood that's forming a clot somewhere. And then nephrogenic is just the inability to recognize ADH. So kidney problems. So the problem is within the kidney. So nephrogenic, it's within the kind of starts in the kidney. So how could we test this? Give them some ADH, see what happens. Because that way, ADH is present. And if they can't respond to it, then it's probably a nephrogenic issue. Right? If they're not responding to it and you gave them some, then it could be a nephrogenic issue. Right? If they do, then it's probably a central issue. They just weren't getting it out. Right? So if they do respond and everything's fine, then it was probably a central issue. So fun stuff. A&P I talked about a minute ago. Again, knowing what words stand for. A&P is something that we naturally produce by the heart, believe it or not. That's why it's called atrial natriuretic peptide. So again, if I can just break down the word, it tells me everything I need to know. Peptide just means a type of non-steroidal hormone, right? That's not what the word peptide means, but in this context, it does. Peptides is where you take a couple of amino acids and stick them together, like usually just like 2 or 3, right? So amino acid, peptide bond, amino acid, peptide. It's a peptide because of its composition. It's made up of amino acids, and it's simple. It's not a long chain where we would call it a protein. So that's a type of hormone sometimes. Non-steroidal hormones can be proteins, they can be derivatives of amino acids, they can be peptides, they can be amines, right? So that's just telling me it's a non-steroidal hormone. The A stands for atrial, which means it's coming from the atria of the heart when the heart gets distended a little bit too much. And the N is the key word here. It is natrium uretic, P. So what that word's telling me is it's saying to P sodium, right? It's telling me to get rid of sodium. So natrium is the fancy word for sodium, right? But again, that's why it's Na on the periodic table. Natride, natrium, natron, sometimes see that. But this is a do-P sodium hormone, basically, coming from your heart. So it's telling you to P sodium, natriuretic P sodium. And when I pee out sodium, so again, if I push more sodium or leave more sodium in my tubular system, if the sodium stays here, the water will follow. If the sodium stays in here, the water will follow. If the sodium stays in here, the water will follow, right? So if I pee out more sodium, I'm peeing out more water. And the reason this usually gets produced by the heart is because the reason we don't want to retain too much fluid volume, if I have too much fluid volume, right? If that's too high, that's going to mean your blood pressure is too high because I'll have too much fluid in the vessels pushing on the wall of the vessels. That's also going to be pushing on the walls of the heart, and that's the stimulus for the production of ANP. So when the heart gets stretched out by having too much fluid inside, it'll automatically start releasing more ANP. So that way you'll start peeing out more sodium, and that'll take water with it. So that'll decrease the blood volume, decrease in the blood pressure. Easy peasy. A lot of times basic mechanisms tell you everything. Let's see. I had a list of things I wanted to talk about today. Let's talk about renal failure. I have later in the PowerPoint a list of things that can cause renal failure. It's a lot. And then today we're going to go over which category did they belong to? Why is that considered a type of renal failure? So if you had me for Anatomy 2, we've done this before. But I do want to point out to you in this particular thing, I gave you the number 1 and number 2 most common causes of kidney failure. Okay. So kidney failure is way up there for reasons people die, but it's not necessarily always put on the death certificate that that was their cause of death. But if somebody has diabetes and they die because of the diabetes, chances are they died because of the renal failure associated with diabetes. Right? And the most common cause of renal failure is diabetes. And we'll categorize that in a minute, which type of renal failure is that. And the second most common cause of renal failure is hypertension, chronic hypertension. Which of course would also cause heart changes, which of course would eventually lead to cardiomegaly, which of course would also lead to congestive heart failure, which of course will be made way worse when the kidneys are starting to fail because they'll start to retain fluid. So it ends up being an endless cycle of bad stuff. Okay? We'll talk about that too. So when you get into renal failure, there's probably 10 different ways to define this. 2 ways that are the most prominent is a decrease in GFR. So if we have a consistent decrease in GFR, that's a type of renal failure. Or if you have a consistent increase of waste in circulation. So either one of those is a basic definition of renal failure. So if I have a consistent decrease in GFR, that's a type of renal failure. If I have increased waste in circulation, again, consistently, that's a type of renal failure. But consistently could be days or years, right? So that's where you start to get into the categories of renal failure. You can have what's called acute renal failure, which may occur within hours, days. And then you have what's called chronic renal failure, which can occur over long periods of time. Okay. Big difference between acute versus chronic is the time frame. So when you get into organ disease, like organ disease, chronic usually means greater than 3 months. Greater than 3 months. That's not always the case for acute and chronic. The word or the number 3 comes up a lot with acute versus chronic. So acute versus chronic. If it's musculoskeletal, I'm just telling you this, if it ever comes up on a board, it's acute is less than 72 hours. So that's less than 3 days. Chronic is anything greater than 72 hours or greater than 3 days. Okay, that's musculoskeletal. So if I have like a swollen ankle because I twisted it, you know, if it's swollen for 3 days, that's still part of the acute phase. Once it's swollen beyond that, that's where we start to move into chronic. And so the treatment would change, right? So if I have acute swelling, we ice it. But if I have chronic swelling, I add heat. So that's where that terminology might come up. It might come up with musculoskeletal conditions. But with organ diseases, acute is anything usually less than 3 months, right? Isn't that crazy? But it's usually within hours to days, you know, usually within hours to days. Maybe 2 weeks would be an example of acute condition. And chronic is anything greater than 3 months. Like it just persists long time. Usually this will be a lifelong disease. It'll last years. But again, acute versus chronic means different things in different context. Okay. So with renal disease, obviously, and you know, kidneys are organs. So acute would be anything less than 3 months. Chronic would be anything greater than 3 months. But again, acute, think this would occur over days, you know, hours to days, maybe even weeks. So let's just put hours to 2 weeks, something like that. That would be most common. Chronic would again be long-term. This is long-term condition. So you can have acute renal diseases like infection, right? You can have chronic renal diseases like autoimmune disease, right? So if I have an acute urinary tract infection, you know, something that happened within 2 weeks, you know, all my signs and symptoms are going to be right up at the beginning, you know, and whether I live or die would depend on did I get past those 2 weeks or not. But with chronic, you might not notice any symptoms at all until it's well established, right? So again, I'm sure y'all know all that stuff, but just in case, there are certain times where these words will change the timing involved. And then again, with renal failure, you can not only have acute versus chronic, you can also have pre, intra, or post of each type, pre, intra, or post. Okay, so we'll make a chart. It's going to have examples. Okay, but before we make our chart, let's talk about what's the difference between pre-renal failure, intra-renal failure versus post-renal failure. All of them are going to be called renal failure because you'll either have a decrease in GFR or an increased waste in circulation because of them. Okay, but it's not always the kidney's fault, right? So if we go back to our basic anatomy, kidney, ureter, bladder, urethra. That's the whole urinary system, basically. That gets led into by renal artery. Let me see if I get another pen here. So let's pretend this is my abdominal aorta. Here's renal artery direct branches off the abdominal aorta. If the problem exists anywhere from here back, it's pre-renal failure, right? So if it's before I make it to the kidneys, it's pre. So pre is back here. So I could have a renal artery embolism, and that would be a type of pre-renal failure because I don't get enough blood to the kidneys to remove waste. And if I can't remove waste adequately, then we'll increase waste in circulation. Therefore, it's a type of renal failure, even though it has nothing to do with the kidneys themselves. I just couldn't get enough blood there. If I have a heart attack, right? I can't get enough blood to the kidneys, we'll increase waste in circulation. That's going to be an example of pre-renal failure. So every time somebody has a heart attack, they're also experiencing acute renal failure. So they'll get increased waste in circulation, which is also one of the ways you diagnose the heart attack, is you'll see the waste in circulation. You could have renal artery atherosclerosis, right? And over time, that's going to narrow the lumen of the renal artery. So you're going to get less and less and less fluid to that kidney. So eventually you're going to increase waste in circulation. So it will end up with a type of renal failure, but it's all pre because it's before we got blood there. You could have hypovolemic shock. I could go into shock because of some type of allergic reaction. And if I go into shock, I lose my pumping power because your vessels become too relaxed, right? They can't maintain pressure anymore. And if I can't get blood into the kidneys adequately, then we're going to back up waste in circulation because we have to constantly get blood to these kidneys constantly to remove adequate amounts of waste, or waste will back up. So anything that prevents adequate amounts of blood or blood pressure getting to the kidneys is a pre-renal problem. Okay. Easy, easy. If the problem is within the kidneys themselves, it's intra. So if I have chronic hypertension over time that has damaged my kidneys, that would be an example of intra-renal failure. If I have some type of urinary tract infection that made its way all the way back to the kidneys and damaged the kidneys, that's going to be a type of intra-renal failure, right? If I have anything that damages the blood vessels inside of the kidneys, like the little tiny blood vessels that go to the glomeruli, the peritubular capillary, that's going to be intrarenal failure. That's what diabetes does. Diabetes damages vessels, right? So vessels that supply nerves, that's why you get neuropathy, right? So diabetes can basically affect every organ system because it damages vessels. It messes up pH. It messes up fluid balances, right? We can't get the sugar into the cells to burn energy. We start burning other things. That causes a problem, but it can affect any organ system almost. But one of the big ones it affects is the kidneys, right? So anything that's happening within the kidneys, we call intrarenal failure. And the two most common types of renal failure are intrarenal failures. And then post is difficulty getting the waste out, right? Because once I've made it through this system of nephrons, right, your nephrons eventually lead to a collecting duct. And that collecting duct eventually leads to a pelvis. So let's pretend we got like a little nephron right here. Here's a loop of Henle. Here's a collecting duct. Right, here's another loop of Henle. Here's another collecting duct. Those collecting ducts will drip, drip, drip into this pelvis, and eventually that will leave going down a ureter, and eventually that will fill up into the bladder, and eventually we will void the bladder through the urethra. But if I get a blockage here and I can't void the bladder, then guess what? It's going to back up. If I get a blockage here, it's going to back up. And eventually, if that waste backs up and I can't get rid of it anymore because everything's too congested, then that waste will seep back into circulation. That's post-renal failure. So pre is problem getting blood or blood pressure to the kidneys. Intra is a problem within the kidneys themselves, and post is removing the waste, right? So post is anything down here. So it's not hard, but now we're going to give you some examples of things that can cause renal failure, and we want to, let's say, put them in the right category. So that's what this slide is doing. It's kind of giving you, well, here's some different reasons people have renal failure. Now we want to categorize it. Is it acute? Is it chronic? Is it pre? Is it intra? Is it post? That's kind of what you're kind of figuring out, right? So again, let me just kind of put the little categories back up here. So you have two main categories of renal failure, or sometimes people call these things kidney disease. So you could have acute kidney disease, you could have chronic kidney disease. So maybe they'll call it CKD sometimes, but it's the same thing, the same renal failure, right? And renal failure can be either acute or chronic. So period of time, like a heart attack, or is it happening over a very long time, like atherosclerotic plaque buildup? Or is it a heart attack versus congestive heart failure, which takes up, right? Blood clot versus atherosclerotic buildup, right? So again, that's hard to determine. You just have to say, well, how would this thing or post some example. So I'm just going to leave this here, here and here, here and here, here and here, rather than doing it here, here. So an example of acute pre-renal failure could be shock. It could be a blood clot, like a renal artery embolus. No, I say the word again so much it annoys the crap out of you, but that's the whole point, is it's repetition, 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 repetition. So if it's pre-renal failure, an example of that could be a blood clot, because if I have a blood clot in the renal artery, right, and it's stuck in here, then I can't get blood past that. Or if I have a heart attack, how much blood is now going to the kidneys? None, because the heart's going to stop during that time, right? And then you get a backup of blood, right? And then compensatory systems kick in if the heart lives, right? Or if we have some type of shock, again, these vessels become too loose. So there's not enough pressure to keep the blood pushing forward. And one thing that we want to maintain is a certain kidney perfusion rate. So not only do I need to get blood to the kidneys, but how deeply, how thoroughly am I getting blood in there? You have to perfuse it. You have to really get it in there. Right. So again, if I'm shocked, I'm losing pressure. Right. Even if I haven't lost volume, the volume's just in the wrong place. It usually goes from the intravascular space to the interstitial space because your blood vessels become too leaky at the capillaries and the vasoconstriction's gone. If it's a clot, it's blocking blood flow to the organ. If it's a heart attack, then we can't get blood flowing for a short amount of time. Right? And of course, if the heart never stops again or starts again, then you die of heart attack, but you're also dying of renal failure at the same time. An example of acute intra-renal failure could be toxicity. You could have like poison mushroom or something like that, or some type of heavy metal toxicity that damages the kidneys immediately. You could have, again, some type of infection, some type of acute infection, something that's happening over like a couple of days, couple of weeks, like it started off with a UTI, but it made its way all the way back to the kidneys. That's possible. Like most UTIs don't make it that far back. You know, most of the time, if I have a UTI, the most common form of UTI is, you know, urethritis, where you get the burning upon urination. And then sometimes people get cystitis, where they get suprapubic pain and burning upon urination. And they'll notice that the smell of the urine is bad and it's, you know, off-putting, and then it aches. So they usually get antibiotics by then. But if you're already a diabetic, or if you've already got some other type of condition going on, then yeah, that UTI can work its way back to the kidneys and you'll get direct kidney damage from that UTI. So then it ends up becoming a nephritis of some type. So if you ever hear like acute glomerulonephritis, and we'll talk about pyelonephritis today, those would be types of acute intra, because it's just an acute infection that's doing it. And an example of acute post-renal failure could be renal calculi, which are like kidney stones. And a kidney stone, sometimes when they dislodge, they get dislodged into a ureter. And that's what causes the flank pain that's associated with the kidney stones. So renal calculi is the same thing as saying kidney stones. So examples. And then when you get into the chronic, same idea, different length of time. So rather than it being like a heart attack, maybe it's congestive heart failure. Maybe instead of just a single clot blocking the flow, it's atherosclerosis blocking the flow. But how long does it take for atherosclerosis to build up? It takes a while, right? How long does it take for congestive heart failure to build up? It takes a while. So the problem with congestive heart failure is most congestive heart failure is left-sided heart failure. And when we have left-sided heart failure, again, your signs and symptoms usually are going to be cough and sputum production. But what caused the congestive heart failure to begin with is a problem with forward flow. So if I have a weak heart and I'm not pumping into systemic circulation very well, then our kidney perfusion rates go down. So when people have left-sided heart failure, they get decreased kidney perfusion. There's less pressurized blood going to the kidneys, and the kidneys will start to run that renin-angiotensin-aldosterone pathway. And guess what happens then? Then when you start to run that renin-angiotensin-aldosterone pathway, that's going to start to conserve fluid and increase pressure. And that ain't no good for the left-sided heart failure, because I'm already having a hard time pumping into the pressure that was there. Now I'm going to have more peripheral resistance, more fluid volume. So that's a problem. So sometimes when people have left-sided heart failure, you need to give them an ACE inhibitor so they're not running that renin-angiotensin-aldosterone system all the time, right? And then once you have left-sided heart failure, that's going to eventually back up and become right-sided heart failure, because that's going to increase pressure in the lungs. And then you start to swell up, right? You get edema everywhere. So one of the classic signs of congestive heart failure is pitting edema. And guess what? One of the classic signs of chronic kidney disease is pitting edema, right? And it gets progressively worse and worse and worse over time, because the weaker the heart gets, the more congested the heart gets, the less forward flow we have, the less the kidneys get the adequate blood that they need. So they start kicking that renin-angiotensin-aldosterone system in, even though they're already hypervolemic, right? They're going to kick that system in anyway, because I can't perfuse the kidneys with the fluid that I have, right? And so the body starts retaining more water, and eventually that's going to make the pressure go up as well, because not only am I, increasing fluid retention with the renin-angiotensin-aldosterone system, I'm also releasing vasoconstrictors. So that's going to make it even harder for the heart to push against. So that's going to back it up even more, which is going to make the kidneys run that system even more, right? And the more and more it backs up, the more and more swelling you get. And that fluid starts to pocket in places other than the vessels. It starts to pocket in the interstitial space. And so that's where that pitting edema comes from. But again, how do we tie in congestive heart failure to renal failure? Because we're decreasing our kidney perfusion rates, which is bringing blood to the kidney. So it's a type of pre-renal failure, right? And atherosclerosis can happen anywhere. It's not just something that's coronary artery disease. That's one of the main places atherosclerosis happens first, because of all the fat that returns from the lymphatic system into the heart. So that's why you see it in the heart more acutely, but atherosclerosis can appear anywhere, right? So if you have atherosclerosis of the renal artery, then that's also going to cause a pre-renal failure. Chronic intra, this is where the chronic hypertension comes in. And again, when you have congestive heart failure, right, we're going to start retaining fluid. That's going to contribute it. So it's going to be contributing to its own demise sometimes. But sometimes this is just people high stress. This is drug addicts, A lot of times when you end up seeing people in the hospital, if you're in any type of acute care, a lot of your patients are going to end up being drug addicts, because the drugs are essentially kicking in some type of sympathetic nervous system. It's making the heart change, the liver's dying from the toxicity, the kidneys are being overworked all the time, so they have multi-system failure because of the drugs. But chronic hypertension, diabetes, and this is the, again, most common cause of renal failure, period, and it's the most common cause of chronic intrarenal failure. So diabetes mellitus, so not insipidus, but diabetes mellitus, the more famous of the two types of diabetes, the insulin diabetes, that's the most common cause of renal failure. So MCC just stands for most common cause. But you could also have autoimmune. So chronic glomerulonephritis is actually an autoimmune disease. And then post-renal failure chronic could be benign prostatic hypertrophy or prostate cancer, maybe, where you can't adequately empty the bladder ever, but it would be pretty rare that this would get so bad that you get kidney failure from it, because obviously the discomfort would outweigh, the likelihood of getting failure from it. But sometimes you might end up having people that are unable to empty their bladder because of some type of cord injury. So they end up going into like a strong sympathetic state. Like they start getting all pale and sweaty, and you're wondering what's wrong with them, but they can't feel. So their body's just responding to that really, really full bladder. But anywho, we're just trying to get the idea here of why certain things would fit in certain categories, and it makes sense. It makes sense. So other things that could cause intrarenal failure, polycystic kidney disease. Obviously, if your kidneys are growing cysts, then those cysts are not going to be viable, tissue, and that's another common kidney disease. But obviously, that would damage the kidneys themselves. You can sometimes have autoimmunity that's affecting the kidneys because it's just affecting some type of tissue that the kidneys have, like lupus can affect anywhere in the body. Maybe you'll just see skin disorder. Maybe you'll see some type of GI disorder, but it can also affect the kidneys because it affects connective tissue in general. Right. Goodpasture disease. I think we'll see that one a little bit later. I think I did put that one in here because it's a common standardized test question. Even though it's a rare disease, it's something that they ask on a test because it always affects lungs and kidneys, always. So if you see a patient that's got lung and kidney issues and everything else has been ruled out, this is your diagnosis. So if they're having both lung and kidney problems, like you're seeing some type of blood gas is all messed up, maybe they're coughing up something, the kidneys are not working. So how would I know that? Maybe we have increased waste in circulation. So if you got lung symptoms, kidney symptoms, and you can't figure out what else it could possibly be, then that's a good fallback. And you could also use cystic fibrosis too. But that's sometimes you just learn it just for the standardized test, and every once in a while you may come across somebody that has it. But let's take a quick break here. Swallowed a bug. Let's take a quick break here. We'll pick back up and we'll talk about a few more kind of random diseases. Shouldn't take too long. So let's just take maybe like a quick 10, 11 minute break. It's 11:14 right now. So let me pause this. And as we pick back up, we're pretty close to the end today. Let's go back to the screen we were on when we were talking about the different types of renal failure. So again, diabetes, number one, for sure. Hypertension, chronic hypertension. Essentially, when you think about the idea that the kidneys are dealing with blood and trying to remove waste from the blood, we can overwork them sometimes. So there are these questions sometimes that come up, am I taking too much protein with my workout? Am I taking too much pre-workout and stuff like that? And they have done studies on these things, and they haven't noticed that there's any kidney dysfunction that goes along with that stuff. But still in the back of my head, I try to be conscientious and aware, am I overdoing it sometimes? Am I working out too hard? And, something that does come up sometimes, and you do have to be aware of it, is something called rhabdomyolysis, and that's back in the muscles chapter. So if I'm taking way too many drugs and I'm working out so hard that I'm going beyond the point of where my muscles can metabolize and they die, and eventually the muscles get, become part of the waste that's floating around in the blood, absolutely, then we can definitely do some kidney damage. But just having chronic hypertension over years and years and years of time, eventually you're going to wear the kidneys out. So heart attack, heart failure, we talked about which categories they might fall into. So acute versus chronic, pre types of renal failure, and so on and so forth. So eventually it becomes pretty automatic for, what category would that fall into? How would that end up affecting the kidneys? General definition we gave, again, if I'm having some type of decrease in GFR, why would that indicate some type of renal failure? Kidneys are pretty straightforward when it comes to removing chemical waste from the body. So when I think about basic functions of kidneys, the number one function I always think about is removing chemical waste from the body. And in order to do that, of course, we need to be able to maintain blood pressure. We need to be able to maintain blood volume. So a lot of the fluid retention and tensioning of vessels do come from the kidneys, like through that renin-angiotensin-aldosterone pathway. But the basic idea is your body's always metabolizing. We're always going to be producing waste, and we need to get rid of that waste just as quickly as we produce it, give or take, right? So obviously there's going to be a little bit of delay in that, and you're always going to have certain amounts of waste floating around in the blood, but it should never start to accumulate. And the reason we're able to keep it from accumulating is because as soon as the waste is made and it goes to the kidneys, we're going to filter it out. We're going to sort through that stuff that goes through there. The waste stays in the tubular system. We can also add more if we're producing it at an even higher rate. We can add more to it. But again, this first step of removing the substances floating around the blood in the glomerulus is just based off filtration. And that's step number one. Let's say this is step number two. Here's step number three. So you have glomerular filtrate, you have tubular reabsorption, you have tubular secretion, and those are the three steps that you need. So 1, 2, 3 for proper removal of chemical waste from the body. If I decrease this one, then that's going to be a problem. So one of the ways that we can have problems with the functions of the kidneys is decreasing our filtration rate, which is going to hinder their ability to remove chemical waste. So if GFR ever goes down, right, then I'm losing step one a little bit, right? So step one, if it goes down, then the whole system starts to fall apart. So one way we could define types of kidney failures if you have a sustained decrease in GFR. And usually anything below 85% is significant, you know. And then once we have, again, a problem with GFR, we're essentially not going to be able to clear out the waste the way we should. So waste will start to increase in circulation. So again, I already went over this with you, but it never hurts to see it again. We can determine if there's waste in circulation or if there's proper content in the urine just by doing simple blood tests, like so metabolic panels. Different types of metabolic panels versus urinalysis. So blood versus urine, what should the blood contain? What should the urine contain? Simple concept is blood should be mostly nutrient, water with a little bit of waste, and the urine should be the exact opposite. Urine should be mostly waste, water with a little bit of nutrient. Again, we'll go over certain thresholds, and it's okay to see a little bit of nutrient in there, but again, you don't want that to start to increase. You don't want nutrient to start to become bigger, and you don't want waste to start to become smaller, right? That would indicate that there's a problem with the kidneys. And similarly, if I can't get rid of the waste fast enough because my waste removal is going down in the urine, where is it going to end up? It starts to end up in the blood. So we start to increase the amount of waste that we have in the blood. So increased waste in circulation means there's not as much leaving in the final urine product, which that's what even a child could tell you that the kidneys do. The child, you know, a child could say, what do kidneys do? It makes urine, makes pee, right? What's in the pee? Waste, right? So if I'm not getting rid of the waste fast enough into pee, where is it going to go? It's going to be stuck in the blood. So that's another way to determine kidney failure. Right? So it's a simple idea. Sometimes we just make it hard with all the different tests that we run. Diabetes mellitus, again, most common cause of kidney failure across the board. And the basic idea is it can damage both large and the small blood vessels. And the small blood vessels is essentially what's getting us in the kidneys. When you think about what a nephron is, the first part's a capillary that has afferent arterioles and efferent arterioles. And then you have beyond that something called a peritubular capillary. And all those are very small vessels, and all those are being damaged by diabetes. And not only does diabetes damage those vessels, it makes them work harder. So imagine having a broken engine in your car and you're making it run harder all the time. It's only going to tear things down faster. Right? So this kind of gives you a little overview of diabetes. If you haven't done all of your disease papers yet that are kind of due by the end of the 10 weeks, throw this one in there. This one's always helpful. And it doesn't really matter which type of diabetes it is, whether it's type 1 versus type 2. Both can lead to kidney problems, but it's usually the type 2 that you see most. So I made this because I think it's hilarious. The one disease to rule them all, get it? The one ring, get it? Sauron, get it? Then nephritis, what does that imply? Pyelonephritis, it's a specific type. Polycystic kidney disease, it's just going over a couple of different diseases. Down here at the bottom, this is called nephrotic syndrome. Nephrotic syndrome is something that was mentioned before, I think, when we were talking about albumin and we were talking about blood in the cardiovascular section. So when we were talking about blood flow, pressure, and all that kind of stuff, I believe albumin was mentioned then, but if not, I'll mention it again, and I'll tie that into a certain type of nephritis. But when we have itises and itis, it usually indicates that we have some type of inflammation of. And when you have inflammation, this has a very specific effect on blood vessels. And one of the most common type of blood vessels, the most numerous of all blood vessels, are capillaries, of course, right? And capillaries, same picture that we see all the time. We always indicate the capillaries as being the little dotted line right here. So regardless of what's entering and exiting, so always, leading into a capillary, we're going to have some type of artery and arteriole. Arterioles are what go on to form capillaries. And then whether that exits as another arteriole, right, like we see in the kidneys, or if it exits as a venule in a vein, it really doesn't make any difference. The capillaries is where exchange takes place, right? And the normal types of exchange we see are things like filtration versus reabsorption. And again, we're talking about capillaries here, not tubular system of kidneys. We're just talking about capillaries, right? So when we're in the nephron, of course, that filtration comes up right here. This is a glomerulus, and your glomerulus is a capillary. So what is its main job? It's filtering. So this confuses people a little bit. Well, if a glomerulus is a capillary and it's filtering right there, does it do any reabsorption itself as a capillary? Yes and no. Yes and no. A glomerulus can reabsorb, but it usually doesn't reabsorb anything significant unless you're diabetic, right? And then it does reabsorb, and then that changes the pressures in here, and then it recirculates again. So that becomes an issue. So when you're dealing with a glomerulus, we don't really see a lot of reabsorption unless there's a big problem going on, right? In a glomerulus, we're just seeing filtration, okay? But here, we're just looking at general capillary function in the body, right? And on the arterial side of a capillary, we see filtration, right? So that's what's driving GFR. The glomerular filtration rate is the filtration that we're seeing in a capillary. And that, of course, is controlled by CHP, right? But what's leaving the capillary is all based off size, right? So that's why when we're drawing the capillary, we draw this little dotted line right here, which is basically saying big stuff stays behind, little stuff can pass through, right? So the plasma, of course, is fluid. It can pass through. Small electrolytes, certain metabolites. A lot of these things are very small substances. Glucose is a very small substance. It'll pass through all the time, right? Amino acids, they're very small substances. They'll pass through all the time. But you also have things like creatinine and blood urea nitrogen. Those all pass through, right? And it's up to the tubular system to determine, well, what are we going to keep versus what are we going to get rid of? So once we get into the tubular system, all this filtrate comes in here, right? And a lot of it's good stuff, like nutrients. So when we go through the process called tubular reabsorption, that's different than this type of reabsorption, right? This is capillary reabsorption. Don't worry about it right now. When we get into tubular reabsorption, that's where we can take stuff from the tubular system and put it back in another capillary, right? But what if I get a problem with the glomerulus itself and that glomerulus becomes inflamed, right? So sometimes if a glomerulus becomes inflamed, you might see terms like nephritis or glomerulonephritis. And when we get inflammation, right, the way that affects capillaries is it ends up making the little spaces too big, right? And again, that's useful in certain instances, not in this one, right? So when you get inflammation of a glomerulus, let's pretend we got a glomerulus a little bit closer here. So let's say here's afferent arteriole leading into a glomerulus. Here's my glomerulus right here, and it's inflamed. So now I've got these big spaces in here because that glomerulus itself has become inflamed. So as this blood is coming through, not only are the small substances leaving, they're supposed to normally leave along with the fluid that pushes it out, but certain big substances start leaving too. So when you start to get some type of nephritis, inflammation, or glomerulonephritis, we start to see big stuff in the final urine product, right? So you might start to see too much protein in the final urine product. You might start to see red blood cells in the final urine product. You might start to see white blood cells in the final urine product. You might start to see casts, which are kind of waste of white blood cells. It's kind of like almost like the outer coating of a white blood cell. So you start to see these larger substances in the final urine product, and the only thing that could explain their presence could be some type of swelling or inflammation that's going on here, or they somehow got added later. Obviously, I could get a catheter going up a urethra, and that could cause maybe some damage that could lead to red blood cells. And then if you get an infection, that would lead to white blood cells too. But it's really not going to change how much albumin is there, right? So when we start to see protein, red blood cells, white blood cells, and casts, that's indicating it's a bigger problem, right? Maybe not coming from a damaged urethra, right? But maybe the actual things that are pushing into the urine product themselves. And not only are we going to start to see these things increase in the urine when we have inflammation of the kidneys, because when we're inflaming the kidneys, we'll inflame these nephrons, and the first part of a nephron is a glomerulus. So we start to see large stuff in the urine, but it also starts to decrease in the blood. So in the blood, you have less protein, right? So that's something that'll indicate that we have some type of inflammation. Right. So nephritis, what does that imply? It implies that we have some type of inflammation going on with the nephrons, right? Why do we have inflammation? There's no telling, but the fact is it's noticeable because I'm going to start losing big substances that should have stayed in the blood and should have never filtered out to begin with, right? Because the filter itself is broken. It's become too inflamed. It's become too permeable, right? So that's how you would tell. And sometimes it's due to infection. And if it's an infection that's causing it, maybe pus will be involved as well. So that's where the term pyelonephritis comes in. So sometimes they have really weird words for pus, like pyelo might imply that we have pus associated with something. Purulent is another word that sometimes implies pus is involved. So this would indicate that we have some type of active kidney infection going on, and that infection is what's caused the inflammation, right? So certainly you might end up seeing cells in the urine, but also signs of sickness in general. So again, the itises, the nephritises, the glomerulonephritis, the pyelonephritis, it should make a little bit of sense. So once those capillaries get inflamed, we're going to start losing big stuff. So the big stuff's going to start leaving the blood, getting into the urine. We're going to start seeing stuff in the urine that we shouldn't normally see. Frothy urine, that could indicate that we have a high protein content. Cloudy urine sometimes indicate that we have a high protein content. And again, protein's not something we should normally see in the urine. But the more inflamed the kidney gets, the more likely it's going to be there. And it's not terrible if we see a little bit of protein in the urine. Don't freak out if you get a urinalysis and there's a little bit of protein in there. Use context clues. Am I consuming tons and tons of protein because I'm a weightlifter? Am I tearing down a lot of muscle cells because I'm a weightlifter? Then it's going to be more common to see a little bit more protein in the urine, but we don't want it to be on the extreme. Polycystic kidney disease, just be familiar with this, be aware of it, be aware that it exists. It's one of those diseases that are more common than you think. It's something you'll run into in your lifetime, I am sure. Okay? But it basically is just telling you that the kidney starts to form a bunch of cysts on them, right? And if you have a cystic organ, then that organ's not going to function as well as it could normally. Sometimes it's seen on an X-ray where you have these very enlarged kidneys. In real world, polycystic kidney kind of looks like something off a horror movie. Just very lobular looking. Look at that. Isn't that wild? So you can imagine. So here's normal sized kidney. Here's a polycystic kidney. Isn't that crazy? So on an X-ray, it might be something that shows up. Right. So look at the size of these things on a comparison to, like, say, some of these lumbar vertebra. Most kidneys, like when we're trying to think about how large are kidneys, remember what we said before, kidneys usually run from about T12 to L2, L3 region, right? So that means they should be about maybe 4 vertebra large. So that's not very large. You usually can't see kidneys on an X-ray. I mean, that's not something that's going to put up a lot of shadow. But here we're seeing the kidneys, and look how massive they are, right? You can actually see the outline of it. That's not kidneys, that's just gas in the digestive system. But the fact that you're seeing them at all, and here you got some calcification going on, right? So the fact that you're seeing the kidneys, and look how many vertebra it's taken up. So that's S1, that's L5, L4, L3, L2, L1, T12, right? So you got T12, here's the top of a kidney right here. 1, 2, 3, 4, right? Almost going all the way down to L5 over here. So that's too big, how big those are. So that's something that you'll run into. And then nephrotic syndrome, the periorbital edema is what gives it up. And we talked about this before when we talked about blood contents, filtration, reabsorption. Nephrotic syndrome, the basic problem with this is you're losing too much protein. So you're losing protein in the final urine product. And so it's being lost from where? The blood, right? Because that's what the kidneys do, is they cleanse the blood of waste, and they're supposed to leave behind the good stuff, and the waste gets sent off to the bladder, and the good stuff goes back into circulation. But if I'm losing too much protein to the final urine product, that means it's not as much in the blood anymore, right? So again, forget about the kidneys for a second, just going back to a normal capillary. Capillaries work because we have certain forces pushing blood out and pulling blood back in. The forces that are pushing blood out is mostly capillary hydrostatic pressure, along with something called interstitial colloidal osmotic pressure. One pushes out, the other pulls out. This is the stronger of the two forces. And when you push substance and ions from a capillary to an interstitial space, we call that filtration, right? But we need that fluid back eventually, right? So this fluid eventually will come back in through a process called reabsorption. And the main way we're able to maintain reabsorption is we have a higher protein content in the blood than we do the interstitial space. And that's what's going to drive most of my capillary colloidal osmotic pressure. And the plasma protein that's in the most abundance is something called albumin. So if somebody's got nephrotic syndrome, they're going to have albuminuria. You're going to see a lot of protein and albumin in that final urine product. So they're losing a lot of protein. And when they lose that protein, now reabsorption goes down. So fluid gets stuck out here in an interstitial space, and you start to see swelling. And one of the places where we see it most acutely is around the face with the nephrotic syndrome. So they start to get that, what's called periorbital edema, right? So what causes it? Hard to say. You know, it could be an infection, and then once the infection goes away, it'll go away, right? But it's hard to really tell where it's coming from. But how do we identify it? Like this. What's going to be the problem? I'm losing too much protein. And if I lose too much protein, I can't reabsorb fluid around capillaries. So the fluid gets stuck in the interstitial space, and we start to get a lot of swelling. And I think that's pretty much all we needed to talk about with the kidneys today. So that is the end of our urinary system. Let's go back to the module real quick, just showing you where we're at here, 7:25. We just finished up our Zoom meeting for urinary. Last week, we talked about a lot of the basics, nephron, anatomy, renin, angiotensin, aldosterone system. Today, we talked about what happens when it falls apart. So we did a lot of the pathophys. Thursday this week, we're going to do the same with digestive. We're going to talk about a lot of the basics on Thursday. So we're going to trace food through the digestive system, talk about normal stomach cells, what they do, all that kind of jazz, just a lot of the basic stuff. What are the different components of the digestive system, what organs are involved. And then the next week, which is our last week, we'll talk about some of the pathophys. We're going to throw in liver as well, and talk about things like hepatitis. And then the following class meeting, so our last class meeting on 8/3 next Thursday, we're going to briefly talk about neoplasms and cancers. I'm just going to give you the basic format of the PowerPoint again, but we'll probably treat this class as a big Q&A class because our exams and our papers are essentially due by the end of next Friday. So we're just trying to get prepared for our final exam. Again, final lecture exam is going to be open book, open note, but it's timed. So you'll get 2 hours for that test. So we want to have as much information stored in our heads as we can so we can save time for the questions that we do need to look up. But again, I'll talk about this more next week. So that ends it for today's meeting. So I'll replace our Zoom meeting with a Zoom recording in just a little bit here. And I'll see you guys on Thursday. If you got any questions, stick around. If not, have a good rest of the day. Thank you all very much. Have a good one. Thank you. Thank you.